This is ASAP Pathway. Hi, friends. Welcome back to another episode of the ASAP Pathway podcast. Your host today, Dr. Stacy, and my partner, Dr. Michelle, is here today. Yay! I do love when you guys come on with me. It changes the dynamic up. So say hi, Michelle.
Hi, everyone. I'm so happy to be here as usual. I want to be here all the time, but it's hard. But
Well,
how
because you
can
work
not?
7 days a week, so you you can rarely come on. We're
How
we'll
can I? Oh, go ahead. Sorry.
I will razz you a little bit. I mean, she's a CE junkie, and our guest today, Dr. Kip Covington. Welcome.
It's good to be here.
He knows all about Michelle's CE junkiness, so we'll have to dive into how you two know each other, how we all know each other, and I'm really excited to have you today, Kip. It's funny because before we started recording, I mean, you're just so well known in the sleep TMD world. And I'm like, how have we never actually met? Like, I know all about you, I hear all about you. And then this is like the first time we're meeting face to face today.
Yeah, I know. I felt like we have met. I know we haven't, but
I know,
you
I
know,
feel the
our
same.
worlds have crossed a ton of times, and I don't know how we haven't sat down.
100%. Well,
Sure.
I'd like to introduce you to our listeners today. So, again, let me get my readers on, everybody. I have an eye doctor visit for those. I might have some new glasses next week. All right, guys. Dr. Covington. He's a nationally recognized leader in dental sleep medicine and TMJ therapy. He's the founder of two referral-based specialty practices, South Carolina Dental Sleep and TMJ, and Carolina TMJ and Sleep Solutions. They focus exclusively on helping patients find relief from sleep disordered breathing, craniofacial dysfunction, and chronic facial pain. With nearly 2 decades of clinical experience and board certification from the American Board of Dental Sleep Medicine, he's known for blending airway focused philosophies with practical, patient centered care. His practices are built on the belief that patients deserve both structural solutions and effective symptom management, whether through oral appliance therapy, interdisciplinary treatment, or regenerative modalities. He's passionate about bridging the growing divide between different schools of thought in airway and sleep space. Through speaking, mentorship, and collaboration, he's working to unify providers around a common goal, restoring health and function through personalized care and informed patient choice. And that is what we even wanted to talk about today, guys, is all of the different options that exist. How do we inform our patients? We've got a lot of different philosophies on helping people with sleep related breathing disorders and TMJ issues, right? And it's tough for healthcare providers to navigate those waters, more or less, our patients and the public. So maybe we start there. Kip, you and I were talking about this before. Um, just how patients walk into your office and what was kind of your aha moment that like we got to talk about this.
Yeah. I think the moment was I had more than one patient come in so confused that different practitioners, who I will tell you, all of the ones that they saw were great, were they were perceiving negative things being told about the other types of treatments from the providers. And then I was actually driving to go teach a group of pediatric dentists and was listening to your podcast, who had friends of mine on. And I was hearing things that were said, which I agreed with all of them. But there's camps out there that probably unintentionally are saying things about other camps that may or may not be true. And it's leading patients to confusion. So anybody that's listening today, or any of us, we're already going against the grain, right? We've seen things we can't unsee, and we choose to go that direction, which isn't an easy path to begin with.
Right.
But there's a bunch of different paths, and it almost drove me crazy to hear people who were trying to help patients in different manners being said that they were doing harm to somebody or that being perceived by a patient. That I finally picked up the phone and called Michelle and I was like, listen, we got to address this because there has to be a unified, even though we're doing things differently, a unified direction so that a rift's not caused between different camps that are all trying to do good. That would kind of simplify it.
And the timing of that call, Kip, was perfect because I just came from an airway prosthodontics workshop at Spear, and in airway prosto. So, like you said, this airway, sleep dentistry, all of these things that we're doing is already a little bit out of the traditional wheelhouse of general dentists and dentistry per se. So it's a new thing that's coming on board in our industry. And then Spear has this airway prosto workshop, which traditionally has been taught by Jeff Rouse, and it's coming from a dentistry, restorative dentistry standpoint. And then recently they changed the curriculum and they added Jameson Spencer on the last day. So it's a 3-day course, right? So 2 days of Jeff Rouse, 1 day of Jameson Spencer. And both of these doctors are mentors of mine. And so this is like my whole practice in a workshop, which which is perfect. And I love mentoring. But what I'm hearing is a lot of confusion because you know, Jeff comes from the restorative standpoint, just do dentistry. We're managing all these patients that are really not diagnosed with OSA per se. They're in the sleep disordered breathing spectrum, UARS, all of these things, all the other symptoms. And we're definitely referring them to physicians for diagnosis, but we are doing the dentistry coming from Jeff Rouse. And then Jameson comes in and, he comes in and he's like, I deal with the train wrecks. And
Yeah.
Kip, you and I know each other from Jameson, Stacy knows our story. So we're coming from, and Stacy, you're coming from that world
Yes.
too, right? The
Yes.
dental sleep medicine world.
Yes.
Just do the appliances, make a mandibular advancement appliance, and it's very conservative treatment. It gets to the patient's needs pretty immediately.
Yes. It's called rescue breathing. I mean, someone needs to breathe tonight. And so that's what that approach is more like, hey, they got to breathe. It's like CPR. You got to get it, get that air in there.
And so the attendees are like, whoa, this is a complete different change of tactics because it's like, well, throw the appliance. No, I'm saying throw the appliance, but make the appliance, get the patient better. But, coming from a restorative standpoint, we were talking about, the nose, we were talking about structure, we're talking about, well, if the denture, if you equate the teeth to the denture, is the base plate the right size? So we're coming from a totally different place initially, and then we end with oral appliance therapy. And that is the spectrum. And Kip, that's exactly what you're talking about. There's a spectrum there, and there's many, many options. And but people do get confused because it's like, well, what's right for a person? What's right for the patient in front of you?
So I would like to back up a little bit because we are talking with our dentist hats on right now about these camps, and dentists listening are like, and maybe not all dentists would even understand what we just said. Some dentists would be, your average dentist doesn't learn any of this in dental school, not much. I mean, we get an hour of it. So some dentists are like, what are you even talking about with airway prosthodontics and what?
Yeah.
And then you've got, mandibular advancement devices. They'll be familiar with that, but they're not going to be so familiar with what Jeff Rouse is talking about, Coy Spear, all of that. They're not going to be very knowledgeable on that topic. So, but the public, the person listening, the patients walking into your office, my office, Kip's office, they're going to be like, what the heck are you talking about with any of this? So maybe we talk about the different, you said it's a spectrum. So, and it's being taught in one course, which is great. So it gives dentists options, but it also gives the patient options, which is like what Kip's mission is, right? Like we want to give patients options and personalize the care, and then they can pick what's best for them in the moment with their finances and their lifestyle and their family dynamics and where they're at in life. So what's happening is it's being viewed as one is right, one is wrong, when it really shouldn't be looked at that way. It should be looked at, they're all right, but what works best for you and your family. So can you explain the different camps, if you will, that are out there right now on helping? This is more adult, correct? This
Yeah.
is adult airway.
Yes, somewhat. So I think the TMD world has taught me so much, right? So I tell every new patient that walks in, I spend 90 minutes with a new patient TMD because I'm seeing I'm seeing the train wrecks, and so I tell every patient, whether we decide to treat you or not, my goal of today's appointment is for you to understand what your problem is and for you to know the options that you have going forward. And if you win that battle, half the battle's already done, right? So I think what we do, there's a lost art in diagnostics, whether it's pediatric, adults, TMD, sleep, airway. We as dentists jump to procedures far too often. And Michelle and I were talking. I think so. There's all these camps that are teaching these things, right? So one of the best courses I think I ever took was something called an airway. No, it's called, what was it called?
AMR,
Airway mini residency.
Yes.
Taught by Mark Cruz and Barry. Say his last name.
Rafi, yeah.
I always say it wrong. I was flying to Jersey and California from South Carolina. And I remember getting to the very end of that being like, we have learned so much over these 6 weeks session. Like it was all year. And we never learned what to do. And people were frustrated with that, but I think it's the most valuable thing I ever did because it was learning the diagnostics, right? So, and patients care about that. Patients, all they want to know is what's my problem and how can I get better? We get in the weeds as dentists on saying, hey, here are all the procedures. I watched somebody a friend of mine put on his website yesterday, doing a joint injection to unlock a jaw joint. I'm like, no patient wants to see that. All they want to know is that, how can you get me better? They want to know the outcome, right?
Thanks for the tip, Kip. My team just filmed me yesterday doing that, and they're going to put it on Instagram, and maybe I should just block that.
Yeah, I don't know that they want to see the.
So this goes to everything we do with marketing too. We think like I don't think like most dentists. I think a unicorn in my class, but I'm not the same personality as most dentists. But if we think like dentists, we're going to do things very procedural, right? So all these camps are awesome, but remember they're taught by dentists. And just like you said, the patient wants to know, what are the outcomes? What's the problem? What are the outcomes? And then how can we get there, right? So how many times do y'all get a question of, where do I start? Where do I go learn about this? And I think entry level, where somebody enters this world, is a big deal. I think it should be voiced that, hey, there are a lot of philosophies out there. Know that when you enter one, that there's other things out there. And it should be when you get into this world, it should be our goal to strive to learn more. So I have changed my philosophies 10 times over the last 20 years. And I love, if there's something else out there, there has to be truth to it or it wouldn't be there. So in the TMD world, you got all these philosophies that people are like, oh, no, you don't want to go learn. Let's call it neuromuscular dentistry. Let's call it whatever we want to do. To me, I'm like, no, I want to go learn. Why are all these people doing it that way? And they're getting success. And something I say in my office to patients all the time, my job here is to have the biggest toolbox possible. And then be really good at figuring out which tool to use. So even when you start talking ortho and expansion on kids, you've got a million different techniques, right? And I think people also need to learn that we're in the frontier of this. I keep a picture of, I was texting Dr. Remmers the other day, and most of our sleep physician colleagues have no idea who John Remmers is. I'm like, this is the guy who invented the first home sleep study system. This is the guy who helped invent the CPAP machine. This is the guy who helped come up with the AHI with Christian Guilleminault and all these people. I was like, and he's out there teaching, and it's awesome. But that reminds me all the time, we've only been talking about this for a generation.
Yeah.
We've lost.
It's a new science. It's a
right,
new
so we
science.
should know it all.
Yeah.
and we're not our creator. So it's like we're trying to fix these things that
Yes.
is already in a broken system.
Yes.
So give grace where grace is due. Is people are trying to learn things, and Shurisagi always says there is no innovation, there is no research without innovation. And I think we have to remember that we're in the innovative part of this, and it'll still be innovated by the time we're gone. That people are figuring these things out, and so I tell patients a lot too that I'm like I give myself the freedom to make mistakes because everybody else is.
That's right.
So, um, but yeah, on the airway pro stuff, Jeff Rouse teaches that course beautifully. I think it's an awesome place for people to jump in because it is so research based. I came back from from airway pros at Spear one time thinking I was going to cure everybody by lip taping them,
So true.
and so this is an interesting story. So not many people could have been in this scenario. I took over a guy who was doing dental sleep devices in the 80s. So he was friends with, so you had Rob Rogers doing things up in Philadelphia. You had uh, Keith doing them in Texas. And then you had this guy in Greenville, South Carolina, that they were all meeting together in Rob's basement and places, learning about these mandibular advancements. So I had tons of patients wearing taps from like the
Yes.
80s and 90s. And they were mostly retired physicians because that's who my predecessor hung out with at the golf course. So I came back from an airway pros workshop and then hanging out with Noah Siegel one time, learning about nasal breathing. And I was like, you know what? I'm going to take all these old dudes and start taping their lips shut. And what I learned from that, like it was, your classical older man sleep apnea, who everybody thought had sleep apnea then, is I was improving brain fog, decreasing nighttime urination trips, improving AFib with lip tape. And I was like, my gosh, only one variable with all these patients changed. And so I was like, wait a minute, maybe we should start with this. And that was what Jeff was teaching. And people will learn about the Seattle protocol. And it's all about trying to control function with anatomy thought about it. So like for those that have no idea what it is, kind of the protocol is to work on nasal breathing, lip tape, then you put in a mandibular advancement, or sorry, a mandibular orthotic to open the airway. Then you would open it again, bring the jaw forward, and you're playing with mandibular position to find where could you theoretically restore a patient to improve their breathing. But you had to start with nasal breathing. And I think that's lost even in the medical side of things.
Yeah,
Like,
it is.
why would we have a nose that's a third of our head that provides so much value and nobody's attracted to the opposite sex because of their nose? So it's got a purpose there. And if we don't start with that, and that's the TMD side of our practice too. If you don't get somebody nasal breathing, you're battling up a hill that is being you're rolling back down. So
100%, yeah, because nasal breathing, we say it a lot and we've studied it. But when you're doing cases and when you're doing, it doesn't matter, ortho, oral appliance, TMD,
Yeah.
all of these patients, they do benefit when you open up the nose. And so, you're talking to Noah Siegel, our ENT colleagues, they really, I think they're becoming more and more aware of the importance
Yeah.
of nasal breathing. Sometimes it's a challenge, right? Right, to look for an ENT who can support us. Same thing with medical providers that they're looking for dentists that can support them. So really, this conversation is so important, not just because we don't want to confuse patients, but Kip, to your point of saying this modality, this field is new in dentistry, and having this misunderstanding of one technique is better than the other and this approach is better than this approach puts a lot of kind of infighting in dentistry. And then we have our medical colleagues kind of watching and also looking to see who they could work with. And if
Mhm.
there's this misunderstanding and infighting of my technique is better than yours or this is the only way to do things, it just doesn't serve our patients, right? It doesn't help our patients, but it also doesn't serve the collaboration between dentists and physicians.
Well, if we could just talk about, so when you guys are saying the words airway prosthodontics to the average person listening, they don't know what that means versus a
Right.
mandibular advancement device.
Yeah.
So, and some may be more aware of the mandibular advancement device or stabilization. Sometimes that's all we need to do is just stabilize the mandible. Not even necessarily advance it much, but keep it from falling back. The mandible's the lower arch. The
Yeah.
tongue is attached to the lower arch. So when we're stabilizing that, we're keeping that big beefy tongue from falling back into an airway. And like, that's an immediate thing. That's something you can do right now to help somebody breathe better at night if the obstruction is more tongue based. Um, we can get into whole where all the areas of collapse can be occurring, but there's certain areas of collapse where maybe an advancement device doesn't help as much. But for the most part, a lot of times it can be the tongue falling back, the mandible falling back. But then airway prosthodontics, that's more of how to restore the dentition and basically make more room for the tongue. You're asking questions of, hey, as a dentist, before I put all these crowns in, before I make your denture, am I making this prosthetic
Mm.
in your mouth in a way that would be neutral to your airway? Would it be negative to the airway, or could I actually be helping your airway by making more room for the tongue? So there's two different camps, and you can see why maybe one camp might be saying, but this is more of a solution, long term, not necessarily an overnight snap something in piece of plastic. And then the other group's like, yeah, and how long is your procedure going to take till that patient can breathe right?
Yeah.
And we're also looking at jaw joints, and sometimes the advancement devices helps with jaw joint issues too, as can the airway pros. So it's not that one is right and wrong in general, because everyone's helping patients. Everyone has their stories, right, Kip? Like, all the camps can give you their success stories.
Yeah. And stories sell, right?
Yes,
When
they
you, when
do.
you when you can tell a good story, you can sell about anything.
So
Um,
true.
so I know exactly where you're headed. I think to simplify that is: are we living in the control or resolution strategy? Those are kind of terminology I use. Are we trying to control an issue? Or are we trying to resolve an issue? And I think what I've had to do over the last 10 or 15 years is learn to think how my physicians think too, um, because that's a lot where my patients come from. And so physicians are used to that. Let's say we're dealing with hypertension. Are we controlling it with medication, or are we going to do lifestyle changes to resolve the issue? Right. Cancer. Are we trying to cure cancer, or are we trying to use chemo to buy time? Like, are we, curative or resolution, whatever you want to call it? And I think that's what we have to think about in our world. Kids going to be a little bit different. It's like, to me, it pains me when I see a kid put on a CPAP, because we all know about facial growth and development. But I always ask the next questions, like when we start talking about any of these, I'm like, how did we get here? So I think I'm
Yeah.
one of the few male dentists who's gone and sat through breastfeeding classes, because I was so curious of like, why are we ended up with narrow palates and like this whole, is everyone
Yes.
outside? And that's a whole nother conversation for another day. But I think if you put it in that boat, and then what does the patient want? Like right now, I think we're seeing something awesome in America where people are wanting resolution strategies for their health and wellness, and they're sick and tired of the control strategies. Control strategies just being pharmaceuticals, right? People are coming at. I've had so many patients say, "Why is my physician not talking to me about diet?" And I'm like, because they did for 30 years and nobody listened.
Mm.
They are so burned out about that conversation, and now you're asking for it. So, and again, I think that's some of the regenerative stuff we're doing in our practices now that's shifting that conversation. It's like, all right, we've got you in this control strategy. Would you like to regenerate your tissues to actually have the jaw joint that's supposed to look like a 30-year-old jaw joint, not an 80-year-old jaw joint? Um, so, but like what you're saying is like, what are we attempting to do? We're all attempting to help somebody. And there are tons of patients that want to come into our office that they just want their issue controlled. Cool, your choice. And there's a ton of patients that come in there like, no, don't just put me on a piece of plastic. I want surgery. How do I fix this thing? All right, well, here are your options. it's not our job to decide what the patient wants. Everybody wants different things.
Right. Yep. Valid.
And I don't know if y'all,
I
have you
love
ever,
what you said, Kip. Your job is to have the biggest toolbox available so that when that patient comes into your chair and says, this is my problem and this is how I want to solve it because X, Y, and Z in my life, then you have a choice in your toolbox to fit that patient's desires and needs.
And if you are not CE junkies like maybe Kip, Michelle, especially Michelle and I, but and say you don't want to learn how to
right,
do all the different things in the toolbox, right? The biggest thing, and Kip, you hit on this earlier, it's understanding, we say this a lot in ASAP. What is your diagnosis?
yeah,
You have to understand what this patient needs and listen and really do some investigative work to figure out where they're coming from. So they might need the ENT. Maybe they're open to expansion and maybe they're open to surgery, MMA. You know, maybe you do an oral appliance, but they're like, I really don't want to wear this forever. And if this device works for me, how do I change this maybe more definitively or quickly? I don't want to go through 4 years of expansion and then still, maybe I still have apnea, you know? So there's all these different options out there, but I'm urging who's listening right now, just start with, like Kip said, start with the whys. Why should you even treat this? Why should we be asking these questions as dentists when we get very little training on it in dental school, maybe a couple hours? Why should you be stepping out and getting so much education on this? I mean, our American Dental Association is saying we should be incorporating this in our screening and intervention techniques as dentists, but then start doing maybe intervention on what you want to do. But you need to find out who your colleagues around you
yeah,
are. People like Kip that are doing different things. And Michelle, like I just referred a patient in Missouri. She's happened to be going to Delaware. And I'm like, look, there is no one I want you going to for your jaw joint evaluation other than my partner in ASAP, Michelle, Dr. Weddle. So here she is seeing Michelle, and already Michelle's unlocked her jaw joint. She's feeling better. She's in an orthotic. So I'm not doing that necessarily, but I know who my
right,
go-tos are.
yeah. And they're out there. Like here's a funny story. Years ago, I was learning all about myofunctional therapy, and I was like, there has to be somebody in this southeast. So I'm searching all over the place, and I had no idea. Y'all probably know Autumn Henning.
Oh
Uh,
gosh, yes. Yeah.
5 freaking minutes down the street from me. She's out teaching, and I call her and I was like, "Hey, where have you been?" And so there, and then you find people that want to join the journey. So like the only time I've ever had a true couples massage was actually with my buddy who's an oral surgeon. And
Oh, that's funny.
I called him one time and I was like, "Hey, Jim, I need to send you a bunch of patients for orthodontic surgery," and that was his specialty. He said, "Yeah, okay." I said, "Well, I need you to do your surgery different," and you can only say that to somebody that you're friends with,
That's right.
right? And he's like, "Okay, I'm listening." I said, "I don't need you to listen to me." I said, "I need you to listen to these surgeons out in Orange County." He's like, "Okay, when we going?" I was like, 3 weeks. He's like, "I'll clear my schedule." So he flew out, listened to some of them, and it was so funny. He was on his phone half the lecture, but then he watched the surgery component. He looked at me and goes, "Yeah, that all makes sense." He's like, "I'm a surgeon. You just tell me where to put the bones." And I was like, "Oh, that's all he can." Like he's like, "That's a different mentality,
It is.
right?" And so you have to understand that with people is like, what is their mentality? And now he got a group of 30 something oral surgeons to do their surgeries different. All right, so I learned this the hard way. Michelle knows a little bit about this, but I tried to introduce pediatric airway in my practice pre-COVID. I brought somebody in that was incredibly talented into my community that was doing all the cool things. She was doing, she had a huge toolbox. Okay. I think we were a little early because the community wasn't quite ready for it. But I learned so much in the failures that we had. I remember us going out and teaching, and somebody would say something like, "Hey, what techniques would you use?" And the conversations were, "Well, just send the patient to us. We'll take care of it." And I was like, you know what? There's too big of an issue for us to try to bring all this in house. And so when it kind of fell apart, I was like, you know what? Why am I not just trying to get all the orthodontists in town?
Yes.
And that has been a long journey of, and fortunately in the South, half the people here are friends of mine. We might be related. Um, but it's like,
Kip
I was
has the
thinking,
most buddies that I've ever known.
I like people. I'm a connector and I like people.
It's a
Uh,
superpower, Kip.
but I remember just going to these people all the time. I'm like, they're not going to see it as fast as I saw it. But now in Greenville, South Carolina, you have so many orthodontists that there are no more extractions taking place. There's very little retraction happening. I just had Bill Hang move at 45 minutes from here. And so, like, this ripple effect is happening, but it doesn't always happen fast. And I remember thinking, I was like, you know what? How much more powerful will it be for everybody to move in this direction versus one or two people here or there? And as somebody who I'm now on our state board, the last thing I want to have happen is a practitioner throwing somebody under the bus because of something they're doing because they're so
Right.
isolated. If we get everybody moving in the right direction, or at least open to that idea, then you have less of those issues that happen. Um,
It's
that
true.
happen.
When you have one or two people, I learned this a long time ago when I first got out of dental school, and I'm gonna botch how he said it, but it's basically what you're saying. When you have one or two people stepping out and doing something different, they're more like pioneers. They're, living on the edge. But when you have multiple people stepping in the same direction, now you have a movement. And that's what you want. You want the movement. And you're going to have, you know, again, this is another, I think, I don't know if this is Jeff Rouse. He says this a lot, but we're smarter together than we are alone.
Yeah.
And you're going to get more perspective and more feedback. Um, I think too, even like, again, our medical colleagues are running out of answers beyond CPAP. And now you've got Inspire, right? They're kind of like, well, now what? And now we're starting to see that Inspire was just everywhere and still is. And there's a place for it. But you're seeing some frustration among patients too, because now it's not fully resolving their airway issue.
Yeah.
And again, we're all navigating this.
Yeah.
And they're saying, okay, now it would be wise for you maybe because they don't do well with CPAP. So now their Inspire patients, an adjunct is now being, recommended to have an oral appliance with your Inspire. So maybe that oral appliance can kind of stabilize the mandible where that tongue isn't having to come out so far with the and Inspire, for those who aren't familiar, it's hypoglossal nerve stimulation. So it detects when you're having an issue and it's forcing the tongue forward with a stimulation of sorts to get the nerves conducted to move the tongue forward. And then an oral appliance is basically stabilizing the tongue or advancing the mandible to keep the tongue from falling back. And you might need it both combined. So again, we've got so many modalities. And I do feel for patients, guys. Like
Yeah.
I feel for them.
It
So
can
I
be
think,
very confusing and hard to maneuver and hard to figure out what the best thing for you is. And if I were a patient, it would be very, very difficult. It's kind of like when we were going through the pediatric airway with my son. That was a long time, 20 years or so ago, right? So, and
that was a
you
long time ago.
he's 18, so it couldn't have been 20, but almost, so 15, let's say. But you're getting different things from different people. And then some people are saying, yes, this is one way to move, this is an option. And then you go to another provider, and that provider's like, oh, why are you even thinking that option? You shouldn't think of that option. That's not a good option. And I put myself in our patient's shoes, and because I've been there for my son and for myself, and I'm sure all of us have been there in our journeys, and this is just one iteration of it, and we have a good idea we don't have the full story, but we have a good understanding of what's happening now versus 18, 20 years ago. But the don't do that, and that's not a good move, and that never works, and that's going to harm you more than help. I think those types of conversations it's difficult for patients to really figure out what to do for themselves, and then you get to analysis paralysis,
Yeah.
and then they're just like, this whole field is confusing, and this whole field is just not for me, and then they get burnt out.
Hmm.
So
So I think the other reason that we see the burnout is it's a total different definition of success. And I think we don't do that enough with patients is define what success looks like prior to whatever we're doing. So you got the patients like in our style practices, patients are coming with an issue, right? Which is different than if you're running a pediatric practice and you're defining the issue for the patient. So if a patient comes with an issue, my favorite thing to do is ask, why the heck did you get a sleep study? And usually it's like, well, they'll give me some stupid reason. And I'm like, no, really, why did you get a sleep study? For you to jump through all the stupid medical hoops that it takes to get a sleep study now, which is all changing, which thank goodness.
Yeah.
But there has to be a why there. And again, it's getting back to the why. And when you find out that why and you get the patient to own the why, like a common one I always find is like, oh, I went because I was snoring. Well, is the snoring bothering you? No, it's bothering my spouse. Well, what would life look like if you weren't snoring? And then you find out, well, I would probably end up back in the same bedroom. And then you find out they're on the brink of not being in the same house.
Yes.
But if you find that driver, then it's like, okay, our definition is to get why the patient's there for a reason. So many times I've treated an AHI and thought that I was successful, and the patient's like, this thing doesn't work. And you're like, what do you mean it doesn't work? You are not dying. And they're like, I am, because I'm not in the same bedroom anymore. So I think this whole apnea hypoxia index, for those that don't understand with sleep apnea, that's how we're measuring sleep apnea. That is one metric.
Hmm.
So I'm hoping, like I've spent way too much money trying to find cheap solutions to measure REM sleep and deep sleep for patients, because from a neurological standpoint, I almost think that's more important. How if people are getting better REM sleep and deep sleep. And when we want to come back and purely talk about TMD issues, we can talk about red light therapy because it jumps into the sleep world. It's fascinating, some of the regenerative things we're doing. But I think if we all just sat with our patients and say, hey, what do you hope happens with this? So I was at a baseball game last night, and a good friend of mine who knows what I do, I sent them to the orthodontist that I wanted them to go to, and they did an airway screening test, and the dad took them instead of the mom, and he said no to everything.
Okay.
And, I looked at him, I was like, he's wearing an oral appliance that I made. And I was like, you idiot, your son does all these things. And I was like, why? He's like, oh, I don't really pay attention. I was like, you should have sent mom. But the good thing is it's not going to really change how my buddy treats him. Blocked out canines, he's getting expanded, he's getting all the right things. But I think it's harder in the pediatric world because we have the job to connect the symptoms that the parents have no idea might be associated with what's going on from a craniofacial standpoint, right? Versus in Michelle and I's your adult-based practices, patients know they have a problem when they get to us. Like when I used to have to do this in my hygiene rooms, like you're here for hygiene, but I'm telling you there's a problem. That was hard.
That is hard.
Sure.
And
that's
yes.
harder for sure.
So it got nice when I became a referral-based practice, but the reason I'm leaving this podcast going to treat 50 hygienists is that world needs to still happen.
Yes, it does. And I was just going to say, and for those of you in the trenches like I still am, having those hard discussions in a hygiene room, and it kind of blindsides the patient, but you're planting seeds and the conversation, needs to happen.
I would watch my hygienist's eyes. As soon as I brought up something airway related, they're like, and we're going to be late for our next
And I'm running behind already.
But I think that's important too, right? I think we all learn this stuff and we get excited about it in your practices. And it's like, how do you implement that in a practice? Barry told the story one time is he almost went bankrupt trying to take his ortho practice to an airway ortho practice. And
Yeah.
there are hills to climb in this world, but I think if you know that you're doing the right thing for a patient, you'll continue to climb that hill, right? And back to why I even wanted to be on this is I just hope everybody knows that there are different camps out there and they're all trying to help people. There's not a camp that I know of that intentionally set out to hurt somebody.
Correct.
That's
There's
not a
some
very good
camps out
business
there
model anyway.
that might, but they're not intentionally doing. I believe that at the core, most of us are good people. Uh, so I think things get skewed when money gets thrown in. But if you know that, then it's like, hey, if you got a guy down the street, like I got a good buddy of mine that does Vivos treatment, and I'm not the biggest fan of it for adults, but I think it's got its uses. I would never throw him under the bus because I know he's doing good things. Um, and I think in dentistry, we get so isolated that
Mhm.
we do that stuff sometimes unintentionally.
Yes, we do. And I do think it happens in medicine too. I think there's all these silos,
Yeah.
David McCarty, he's wonderful.
Yeah.
I love his podcast, Empowered Sleep Apnea. Um, he is fantastic. He's a sleep physician. I really like him a lot, but he goes into the silos and how we have to get out of our silos and we have to start communicating. Um, and, I think to summarize, because we're getting to the end of this, but we have to have a part two, Kip, because I think we do need that conversation about red light therapy, how it's crossing over, um, metabolics. We need to have this discussion, TMJ. So I'm dragging you back for a part two with Michelle and I, if you would be open to that. But
Yes.
just to summarize, kind of, look, if you've got a kiddo that has, sleep related breathing disorders, it doesn't have to be full blown apnea. I mean, we're talking mouth breathing, we're talking fragmented sleep, different things like that from not breathing properly. CPAP is sometimes the rescue breathing that is necessary. They have to have it right now, but to have that as a long-term solution, no, it's not. The physicians know it too. They'll even put, at least my sleep physicians will put, they've recommended CPAP, but then they'll explain to parent the
Mm.
deformities that can occur. So it's not even just stunting, which stunting growth is a deformity, but you know, it's not working with their growth. It's actually working against the growth of the midface. So yeah, look at growth and development. Start looking at orthodontists and dentists in your community that look into craniofacial development and they're aware of the impact on airway. Now, the non-growing person, you're 18 and you're older. Okay, now you got a lot of different options, and that's where all these different camps of, there's CPAP, there's mandibular advancement devices. Those are both rescue breathing. And then you have, okay, oh my gosh, you guys see the balloons that just
Well,
flew?
I was gonna say, what are balloons coming through? What are we
There must be
celebrating?
some new update. I updated it this morning, so I did something to show celebration, I guess. Woohoo! Balloons just flew in front of my face. That was fun. Um, but you also have, CPAP and MAD are more rescue breathing, right? Like, let's get that airway open right now. Then you have things like MARPE, skeletal expansion, airway prosthodontics. Looking for a little bit more long-term solutions might take a little bit more time. And then you have Inspire is more of a rescue breathing as well. It's an immediate, like, let's get the tongue forward. And then you have surgery, maxillomandibular advancement. So there's just educate yourself. There are options out there. It's just what works for you and your why. And I love this, Kip. You said this earlier, understand the diagnosis. But something I started, Dan Clower taught me this a long time ago. I want to give him props. But everyone that sits in your chair, like I love, why did you get to sleep study? Why are you here? What is your win? What is your victory?
Yeah. His book, Achieving Your Victory, that he wrote.
Yeah,
Yeah.
see, we all cross over with this stuff, but that really influenced how I talk to my patients because from a practitioner standpoint, we're like, okay, Are you a positional apneic? Can I get this AHI down? Da, 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 you know, I'm thinking all these things. And then, but they're just like, I can't even, I'm so tired. I can't play with my grandson.
Yeah.
That's my victory. And
Yeah.
you're like, gosh, I would have never even said, hey, are you playing with your grandson more? 4 or 5 weeks into therapy, you know? So it's finding out, it's talking to our patients and finding out what their win and what their victory is.
Yeah. I try to be like my kids. It's like, when they say, why, you give them the answer. And I'm like, why? If you do that with a patient, you'll find what their win or their victory or what their why and their driving force is. And then it's nice to be able to sit with them and be like, hey, I don't think I'm going to be able to achieve this, but we can try. Or look at somebody in the TMD world. It is now rare that I look at somebody and be like, I can't help you. And that took years to get that confidence. But that also it's so much fun to look at somebody that's had 10, 15 years of chronic issues. And you're like,
Mm.
look at them, you're like, you're not nuts. I can help you. So,
I bet you get a lot of tears in your chair.
I bet we get 20% of new patient exams. And I, and I tear up every time. They never.
Yes, like when you just said that, um, we do have people that have been so,
Hmm.
what's the word? They're tired and and they've been looked over, basically called, told it's in their head or, and it is in your head. Yeah, it's called your jaw joint. But they they're looking for answers and by the time they get to us, they're skeptical and they don't have a lot of energy left. They're tired. And so it does take patience, but I hope practitioners listening, dentists, it's funny. You said this earlier too before we hit record. Sometimes you're at the end of your dental career, right? And you're like, do I retire? What's next? And you've done it all: crowns, bridges, veneers, partials, dentures, implants, whatever. Consider sleep. Consider TMJ, dysfunction therapy. This could light a fire for a part two and a chapter two in your career. We see it a
Yeah.
lot.
Yeah, you do. I'm at a unique position right now where one of my missions is I have patients, especially the TMD side of the practice, patients coming from way too far. I've had 3 patients this year that came from different continents. Uh, and it should not be that way.
Hmm.
So in the Southeast, one of my goals, and I have a long history that I'm affiliated with a pretty big group practice that's local, that I want more access to care of what I do, right? And so I'm a unique and I think our breed that I love to teach because I think there's enough people to go around that we should not be scarcity driven.
Yes.
Um, and so one of my goals is to have multiple practices. And one of the problems, most of y'all know our mentor, Jameson Spencer, he looks at me all the time and says, you need to quit treating patients so that you can use your superpowers to find more people to treat patients. And I always look at him and say, but that's not what I want. I love treating patients.
Mm.
And I know there's a time where I may have to give up some of that to continue what my mission is to have people not driving 400 miles to what I think is somewhat simple treatment, but it's not for most people because we've had no education in this world. But it shouldn't be people have to fly around the country to go get treatment. It should be we need to teach more people to get the treatments we're getting.
Okay. On that, Kip, on that. So you're not teaching yet, correct?
So officially now I am teaching at the Medical University of South Carolina.
So how can a person listening, where would you recommend they start?
In which realm?
Okay, let's start with, well, I mean, I'm a big fan of Jameson Spencer, but
Yeah.
I mean, so for me, you're going to get some TMJ, you're going to get a lot of TMJ, and you're going to get a lot of rescue breathing advice too on mandibular advancement.
So Jameson gives me grief, and Michelle's heard this all the time. Jameson there's a mystery referral, like a referral, thank you referral. I think it's like an Amazon gift card. I've never seen it, but I've sent hundreds of people to Jameson's. I firmly believe that is one of the best introductions because he's built the solution to a problem. It is a on-demand 75-ish hours, and he's built a community of people who care. I don't know if you've ever noticed that with the Spencer Study Club.
Yeah.
It weeds out people that shouldn't be there. And it brings in people that are relatively like-minded. And it gives you a little bit of sleep and TMD. I think for those CE junkies that love doing Spear, Dawson, LVI, Pankey, you name it, Coyce, I think Jeff Rouse's stuff is second to none. I think there's people out there like Michelle and I that I didn't have a camp, so I just went to all of them. And I don't do that anymore because my full-time job as a assistant baseball and football and coach does not pay very well, or at all. But my kids are at an age where I don't want to miss things.
Right. Yeah.
So one of the beauties of what I've done over the last couple of years has been able to do incredible patient care and get back my life as a father and a husband and things like that. And that's important too, right? So
Yeah.
you were saying that, hey, I'm about to be an empty nester. That's a
Yeah.
whole totally different time where now it's like, what do you do with, I can't even imagine having the time I used to have back.
I can't either. And it's kind of scary, to be honest.
I
Like,
bet.
it's scary. I'm excited for my kids, but yeah, like we could have a podcast on empty nesting and I could talk for probably 5 hours about my emotions surrounding it because it's a whole different season because you're changing too. But yeah, it's an exciting time. It's a scary time. I have to reinvent like what's my role in their life? But you're right. Different seasons in our lives as practitioners, like how much CE are you able to give? You've got to be realistic.
Yeah.
And,
Right.
like don't put the whole onus on yourself to have to know all of it. My gosh, like you said, you had Autumn 5 minutes from you. How common is that? We have to step out of our office and have some conversations and start calling people, you
So on
know?
that note, like in my community, I know how good that practice is. That if a parent asks me about their kid, and I make their starting point myofunctional therapy because I know they're going to pick up the craniofacial deficiencies, but I like them being there. Versus in the adult population, I want to be the quarterback because I can look at somebody and say, hey, these are the things I think would benefit you. Um, but yeah, back to that question of where to start. You know how many people I've sent to ASAP? You guys have built something incredible for the
Oh,
pediatric room. Um,
thanks.
but there's some certain people I don't do well on a Zoom meeting or this is better than nothing, but I like to be in person, as you can tell by my personality. There are some people that want everything done on their own pace. So I think it depends on what somebody's learning style is to where they would want to jump in on something.
Right, right. And on that topic, thanks for that segue. Before I get to, because we'll have to wrap up today, and I'm going to ask you those three amazing, fun questions at the end in a minute. But for those wanting to learn from a pediatric growing perspective, and when we say pediatric, I mean you're growing all the way up to like age
Yeah,
16
right.
ish. So just because you've got a 13, 14, 15-year-old doesn't mean we can't help you figure something out. But we have an immersion course. We just started our second round for the year. And we've got another one coming up and to register in August. Actually, registration ends in August, but it's, we get together. You have access to all the educational modules. Like Kip said, you could just, kind of do it at your own pace. And then we meet once a month and we talk about the modules.
Yeah, yours is awesome.
I think
Yeah.
that's what's different. And, for somebody like Kip, how you say you like the interaction, live is always the best, but
Yes.
sometimes it's hard, and especially if there's a lot of material. So this is kind of our second best, where you have the time to go through the material on your own time, but then you do have that interaction that's timed and it's frequent enough that it's like touch points so that you can ask your questions or say, hey, I tried this in my practice, kind of like our Sunday chats,
Yes.
Stacy. Yeah, I
Well, and
Yeah.
tried this
it's
in my practice and I was expecting X and I got Y, and I'm like, and I don't like Y. I want to go to X.
Well, and
Yeah.
there's something nice about when we all just hang out and talk and you feel like you're not alone. And that is a big thing. Because, like, when you're a dentist, you're pretty much in a private practice by yourself or with somebody else. And it's just nice to have that camaraderie and talk and feel like you're not alone. We
Yeah.
also have early ortho intervention part two coming up, and you can get the recording for part one. so that you can take part two and dive in. And we also have the skeletal expansion course with Dr. Lipkin. The early ortho intervention is Dr. Courtney Levine. So we've got some
Can
amazing
I say something
speakers.
about that
Yeah,
ortho,
please, please.
the MARPE course? So I don't know whether, Kip, I don't know whether you know this. The MARPE course is a skeletal expander course, and traditionally, what we've had in ASAP is we've had two sessions, and one focused on kind of easier, basic expansion, younger, skewing on the younger, and then the other one would be kind of the older one, the more challenging, maybe adding to piezo, and then also looking at potential side effects, complications, things like that. So how do you prevent that, and how do you get yourself out of it if it happens? But now what we've done is, because the protocol has been, developed over a good amount of time now. So it's been pretty predictable. So the first part this year was focused on the surgery. And it's been pretty predictable, and there's a really good protocol. So the second part, a lot of people are now saying that they're finding challenges with the orthodontics. And many people actually don't even want to start the skeletal expansion because
Right.
they don't know how to finish it. So
Yeah.
the second part is actually finishing the cases, and also considering the orthodontics even before you start. How would you plan the case, and how to look at it orthodontically, so you know that you'll have a successful outcome once you do gain that skeletal expansion. So I think that's one of the things that I don't know, the word is out there, but Ilya has been such a great resource, and he's just so down to earth, and he explains things so well. And he has 5 bazillion cases to show every single
Yeah.
problem
Right.
that we might encounter. And we ask a question, and he's like, "Oh, I've done that. I've solved it A, B, and C ways. Pick your way." You know.
Which is awesome, right? Because again, the tool isn't the most important thing.
And
It's
there
what
you
you're trying to
go.
accomplish. Yeah.
Coming back into our conversation and circling back, you have to have a big enough
Yeah.
toolbox.
What I tell people there is, please do not go take your entry level course from a company that's selling their product.
And that is why we have ASAP Pathway. We don't have a product we're selling, it's clinician driven.
Yeah.
Look, we're going to have a part two. I really want to talk selfishly to
Yeah.
more about what you guys were talking about. I promise Michelle, in my empty nesting life coming up soon, that I am flying, and I'm going to learn more from her with PRF, red light therapy. She, did all this stuff for my patient. My patient's so grateful. And I'm like, I got to learn this more. But I'm going to ask
Maybe
these
we'll
questions.
fly to Kip.
Maybe we
That's what I
fly to
said.
Kip.
They're kept together.
Greenville, South Carolina it can be a nice place to visit. Happy to have you.
Oh, it's beautiful there. All right, ready, guys? Here come our 3 questions.
Love it.
All right, Kip, what is your biggest pet peeve?
Oh, being late.
Ooh, I'm with you. That drives me bonkers. I can't stand it. I'm always early. Michelle's laughing because she's always late.
I'm always late.
I'm
I
not
love
saying
you.
I'm always early, but I think it's a pet peeve of mine. I feel like it's rude to be late.
Agreed. To me, it's like you're not valuing another person's time they've set aside.
Yeah.
I agree with you. Michelle, what's
And
your
it's
pet
one of
peeve?
those things. It's a cultural thing, right? So a lot of Filipino, we always say Filipino time, Filipino
Yeah.
time.
Yeah.
So
Oh,
that's
is that a thing? Are
oh
Filipinos
yeah,
late?
oh that's a thing. Yeah, that's a
I'll
thing.
just always tell my Filipino friends an hour early then and make sure they're there.
That's Filipino time. Well, that's my pet peeve: not having food.
Yeah, she gets hangry really
Yes.
easy.
I've seen her get hangry.
Yeah, those that know Michelle, have some kind of snack in your purse for her or something. Okay, second question. Kip, what is your go-to emoji that you find yourself using all the time?
This one, I don't know.
You're holding up like, I don't know, hands. Like, I
Hold
don't.
on. I guess I could tell you if I go and look at the most used. I think that's probably it. Yeah, that and the nervous face
Oh,
because
it's
yeah.
funny.
But now my daughter has figured out how to build stickers on my phone, and
That's hilarious. I love
so
stickers.
She took a picture of me in the pool on a unicorn float with a thumbs up, and that's probably become my favorite emoji.
That's so great. What about you, Michelle?
I don't know how to make stickers. I'm gonna have to learn that from your
Oh, it
daughter.
is so fun. You take an image and you just push your finger on the image and you can add it as a sticker. And then so you can send it like I have one for my brother. It's like whenever he says something that drives me nuts, I just send this picture where he's making a real ugly face. I send a sticker back to him and he's like, and then he sends one back to me. So it's fun. But apparently there's a
Like it.
whole thing of cringe, like
Oh,
Gen Z says our generation, like we're not supposed to use this, like we use emojis that they find cringe. And I'm like, whatever. I don't know.
Really? Okay, I'm
Yeah.
totally not up to that.
Apparently, a thumbs up is passive aggressive. So you're not supposed
oh.
to send thumbs up anymore. And I've probably sent five of them yesterday. So sorry. Okay, number three. Kip, if you weren't this rock star dental sleep TMJ specialist that you are, what would be your runner-up career? What would you be if you weren't what you are right now?
I think Michelle knows this. I had always wanted to be a marine biologist. Um,
Really?
yeah, and I still have not made it up to her husband's aquarium. I'm an ocean guy. Um, I mean, if I could be the ultimate, it would be a professional surfer, but I'm not a very good surfer at all. So,
Okay. Stick to marine biology. Stick to the scientific stuff.
so
Oh, what
yeah,
about you,
I'd probably.
Michelle?
It's a toss-up. I'd probably either be a marine, not marine. Sorry, that was Kip's. Marketing. Like I love
Oh,
studying.
Yeah, you are so
Yeah,
good at marketing.
I do marketing. I love it. When I see, those commercials, um, what is that? I'm so bad with sports. The football when halftime, and then they have those commercials. What's
it's
the
called
big
this.
football
It's
thing?
called the Super Bowl.
It's called the Super
It's only the
Bowl.
most watched event in the U.S. But yeah, go ahead.
There you go. See, I told you I'm bad at sports. It's a Super Bowl, and when they have those commercials, I love watching them. So yeah, marketing from that perspective, probably. Or I always say I need if I ever need a hiatus from dentistry, I would just go to India, be a background Bollywood dancer because I don't want to be
Nice.
the main dancer because that's too much pressure. Yeah,
Oh, I
and I'm
can
not.
totally see that.
Yeah, so
Totally
good.
see that. Well, guys,
Wait, do you
so,
not answer
Hey,
these
what's
questions yourself?
yours?
oh shoot, Kip, gosh darn it.
Come
Okay.
on.
I agreed with you with being late that, and I hate when people smack their food, drives me nuts. But I'm a big like be on time or a little early is even on time to me. My go-to emoji. Lately, I've been like doing this like hands up, like, yeah, like high five. I don't know why. Just like I'm happy for people or I agree with people. But my backup profession, it's really kind of weird because I have never wanted to be anything but a dentist, but um, I don't know. I'm big on hospitality. I love making people feel welcome and things like that. I think I would open some kind of, you know, place where I can make people feel welcome. I don't even know what that is, but I love it. I love when people walk in my office and they are like, your waiting room feels like a living room. And
That's
I just
awesome.
like making people feel welcome. So it could be like a bed and breakfast, coffee shop, winery combination. I don't know. I don't know that I would pick a profession. I do love to teach. So I maybe throw in some teaching in there because I can't get rid of my scientific head, mind space. But I love making people feel welcome.
Oh,
And
I totally could see you in that role.
like just cozy welcome. I don't know what it is. So I guess that's going to be my part two in life. I need to figure that out. But well, thanks, Kip, for bringing that up. I totally forgot I didn't answer the questions myself.
Yeah.
Thanks for being here today. Appreciate you so much. And it's good to officially meet you, friend.
Yeah, you as well.
Yeah. All right, everybody. Thanks for joining us today. Thanks for listening. Check out the links. We'll have ways to find Dr. Covington and keep the conversation going with him and our courses and our ASAP Pathway newsletter if you just want to know what's up in ASAP. And we'll see you guys for a future part two. And we'll see you next time.
Awesome. Thank you. Have a good day.
You too. This podcast would not be possible without the inspiration of my dad, Dan Becker, and creative direction and editing from the talented Jason Becker, Benjamin, and Judah Walker. To stay connected and keep the conversation going, be sure to subscribe to our podcast and visit our website at asappathway.com. And remember, the information in this podcast is for educational purposes only. It's not intended to be used as medical advice to replace your healthcare provider's diagnosis or recommendations.